Ladies and gentlemen, let's start on the next lecture. This is primary angle closure glaucoma. We've just done the primary open angle glaucoma. Now we want to do the primary angle closure glaucoma. I think one important point to note is that aqueous outflow is obstructed as a result of the closure of the angle by the peripheral iris. Once aqueous is produced, it comes through the pupillary space into the anterior part of the angle and drained away. But if the angle is closed, then there's a hold up on the drainage and the pressure keeps building up, and this is what leads to angle closure glaucoma. This occurs usually in anatomically predisposed eyes and occurs 1 in 1,000 individuals over the age of 40 years. In other words, this type of glaucoma is the elderly. Prevalence increases with age, in women and men by 40%. Predisposing factors are relatively anterior location of the iris lens diaphragm. So you have a relatively anterior location of the iris lens diaphragm, a shallow anterior chamber, a narrow entrance to the chamber angle, and the proximity of the cornea to the peripheral iris enables the angle closure to occur more easily than in a normal eye. In most cases, if you when you're examining the paper, you can have an idea, a feeling that this angle is shallow. You can have that feeling. You can, if you've seen many eyes, a deep angle and a shallow angle, you can easily differentiate. This is the diagram which shows, you can see when there is a closure, the pupil is stuck there. Pressure is supposed to be built up here and go into the anterior chamber to be drained away. If the iris is stuck on the anterior lens surface, this build up here pushes the peripheral iris, the peripheral part of the iris, towards the cornea and closes the angle. So getting the pupillary margin all stuck onto the anterior surface of the lens, the build up there is now pushing the peripheral iris towards the angle, closing it up. That can also lead to, it leads to angle closure. But this occurs especially in people who have generally they have shallow anterior chambers. What are the stages of primary angle closure glaucoma? There's a latent stage, intermittent stage, acute congestive and post-congestive stage, then the chronic and absolute. How long it takes to move from one stage to the other, you can't predict that it will take a day or so. But these are the possible stages in which you can find a patient when you examine them. For example, if you are going to find them in the chronic stage, they'll have a history of what had transpired before they came there. They will have an intermittent attack, maybe gets relieved, then finally they get another attack like that. Latent angle closure glaucoma, the clinical features. Thanks. Shows a shallow anterior chamber with a convex shaped iris lens diaphragm. The iris is convex shaped because of the pressure buildup behind the iris. The pressure there is pushing the iris forward, and it has that concave shape. And with that pressure buildup there, the peripheral part goes in to close up the angle. When you are seeing the patient from outside, obviously the whole anterior chamber looks shallow because of buildup of pressure behind the iris. Close proximity of the iris to the cornea, a normal intraocular pressure. We're talking now of latent and a narrow angle. Without treatment, an eye with latent primary angle closure glaucoma may remain normal or may develop intermittent attacks of acute angle closure. You're recording from me? They're not reading nicely. Are they seeing now? Ask them. They are comfortable now. Okay. Okay. So without treatment, an eye with a latent primary angle closure glaucoma may remain normal or may develop intermittent acute angle closure attacks. Intermittent angle closure glaucoma occurs when the angle is narrow in only one part. A rapid partial closure and the opening of the angle occurs. The level of intraocular pressure proportional to the extent of the angle closure. It is logical, isn't it? The angle that's where the drainage occurs. If part of that angle is closed, obviously the drainage of the intraocular pressure will be affected, to be reduced. So if you have got intermittent attacks, even the drainage will be intermittent. When there is complete closure, that's when there is now a crisis. You find the patient is complaining of pain. So during the attacks, can you increase the size? Is this the slide I was doing? Intermittent occurs when the angle is narrow on one part. Rapid partial closure and reopening of the angle occurs. This pulls the peripheral iris away from the angle. Not treat fellow eye prophylactically. If there is an attack in one eye, you treat the other eye as well prophylactically. What is the treatment? You give them a drug to constrict the pupil. By constricting the pupil, you are pulling away the iris that is clogging the angle. Because that iris was started by dilating, and then it goes and shuts up the angle. So in the treatment, if you give them a constricting drug, it pulls away the iris from the angle, and there's a bit of drainage starting off like that. If that is not possible, laser iridotomy treatment with laser, where you make holes onto the lens, onto the iris. Those are extra channels for the buildup of this pressure behind it to come into the anterior chamber. So that there is proper drainage. Where is my slides? This is slide what? 12. 12. 12. Okay, I need more than that. So go to 13. But before going, I hope people can see the proximity. This is the cornea, the white part, and the iris. There is hardly any space. That's the closure of the angle. And with the rise of pressure, you find there is a edema now on the cornea. Sedimentous. Cornea edema, shallow anterior chamber with peripheral iridocorneal contact, peripheral iris cornea contact. What they call iridocorneal contact. Yes, like that. Okay. So to stop this, you have to make holes into the iris so that some of the aqueous can come to the anterior chamber through those holes. If there is an acute attack, holes there will allow. Dilating of the pupil will also give you a chance for some of the fluid behind the iris to come into the anterior chamber. Later on, after corneal edema has cleared, one can see aqueous flare and cells in the anterior chamber, dilated and congested vessels on the iris, optic nerve head to be edematous, hyperemic, and gonioscopy shows you iridocorneal contact. Gonioscopy, when you see the angle with a gonio lens, it's all closed. There is that contact of the peripheral iris closing up with the posterior part of the cornea. This is what they are calling iridocorneal contact, closing up the angle. And with that closure, that's what raises the pressure. Production is continuing, but there is no outflow. There's no outflow at all. The fellow eye is also a narrow angle. So while you are treating this one, don't forget to treat the other one prophylactically. Otherwise, this one goes, the next day, the next day the patient will have another attack in the other eye. And these attacks can be serious and end up into blindness. Treatment immediate. Once you've made your diagnosis, this is closure, angle closure glaucoma. First, it's very painful to the patient. Treatment is aimed at lowering intraocular pressure through systemic medication like acetazolamide Diamox, 500 milligrams, oral slow release, and the hyperosmotic agents may be necessary if effective, if ineffective. Analgesics, once there is closure and there is pain, you have to give some analgesics. Antiemetics, people may even start vomiting. Topical therapy, give them beta blockers. Why are we giving beta blockers? What are beta blockers for? To lower the intraocular pressure. Okay. Topical steroids to decongest the eye. Which one? It's eye drops. It's eye drops. Beta blockers, eye drops. Topical therapy, I've written there. Topical therapy, beta blockers, BD drops. Beta blocker drops, BD. Topical steroids to decongest. There are also drops, you know. Antiemetics, you may give injection or whatever to stop the vomiting. Analgesics, you can choose which one is appropriate. treat the fellow eye with 1% pilocarpine drops QID until prophylactic iridotomy can be done. This is a very important concept. You've got an attack in one eye of angle closure, glaucoma. You don't want, while they are treating this one, you don't want the other eye equally to end up in the same situation. That's why they say you treat the other eye with pilocarpine. Dilatation of the pupil is what is clogging the angle, leading to angle closure. In this fellow eye, while we are treating the one which is has got an attack now, in this fellow eye, you must put a constrict the pupil, pull away the peripheral iris away from the angle by constricting the pupil. Pilocarpine, yes. It's a constrictor. The pupil constrictor. You are giving steroids to decongest the eye. Okay. Pilocarpine QID drops until prophylactic iridotomy can be done. It's a temporary measure. The pulling by constricting the pupil, you are giving yourself chance until an operation is done to open a hole in the iris, a physical one. You open, you go there, hold it, and cut. Then the fluid will be going the other side, in the posterior chamber. Are we clear? Presentation one, post-treatment. The intraocular pressure normally normalizes by iridotomy or a filtration surgery. Once you treat, eventually you have to do this iridotomy. You can put in a hose, 1 or 2 or 3. People, 1, 2, 1, 2. This allows no buildup of this pressure in the posterior chamber. Any pressure buildup, most of the fluid will come out now through the hose into the anterior chamber, even if the pupil is stuck on the lens. Because you've opened up you're putting holes in the iris, there will be no buildup of pressure there. It's easily coming up now into the anterior chamber. Okay. And you can have spontaneous angle reopening, proceed to treat as intermittent primary angle closure glaucoma, peripheral iridotomy, and that will cut out the serial shutdown. May occur in the presence of peripheral iridotomy 3. Serial shutdown may occur in the presence of a closed angle. So you need those holes. These holes, they can be done with laser, where the laser is available. If it's not available, it has to be done surgically. It has to be done surgically. A small incision, that's it. It's not every institution that has laser which you can use for laser iridotomy. But having said that, even without laser, you can do it. You just need a small incision. You go in peripheral iris and you cut 1, 2 places. At least that gives room for pressure not to build up behind the iris. You put up holes, the aqueous now will come into the anterior chamber. Don't wait and say, no, it's a peripheral laser is what is required. Now we don't have. No, you can treat even without laser here. The principle is a few holes to allow aqueous to move from the posterior chamber to the anterior chamber so that it can drain nicely. The closure of the angle occurs because there is pressure buildup in the posterior chamber, pushing the iris to close the angle. Understand? Production continues because production is done by the ciliary epithelium behind in the posterior chamber. Normally, it has to pass through the pupil opening into the anterior chamber, then to the angle for filtering out. So once that pupil is stuck on the lens, there's a buildup of pressure. and the peripheral iris is pushed towards the angle and closes the angle completely with the pressure building up and a lot of pain for the patient. But if you recognize that, you can do something. Where there is laser iridotomy opens up the pressure, lowers the pressure. If you can't, you have to go surgically. The choice is not to say I have nothing to do, I can do. Well, you are not helping the patient. Clinical features. Trying to get this. I want this. What is this reading? Angle closure. Okay. The clinical features of angle closure similar to those of primary open angle glaucoma, except gonioscopy shows a variable amount of angle closure. Initially, before the attack, understand this is what you see, the angle appears shallow, but there is no attack. Once there is an attack, it's an acute angle closure glaucoma. Okay. So when you're examining ordinary patients, take note about these angles, whether it looks normal or a bit shallow. These are the people, if you think it's too shallow, you give them a prophylactic iridotomy, 1 or 2 iridotomies, and they'll never go into an angle closure while they're still intact and happy. So the clinical features of chronic angle closure glaucoma, clinical features similar to those of primary open angle glaucoma, except gonioscopy shows a variable amount of angle closure. Management depends on mechanisms of angle closure. Group 1, you can have a gradual and progressive angle closure. Treat by iridotomy to eliminate the pupil block. I think I've talked about that. Medical therapy or filtration surgery. Filtration surgery is a trabeculectomy. You give them a trabeculectomy, because the trabeculectomy will be a site of filtering that aqueous from the anterior chamber under the bleb of the trabeculectomy. Then they can go subconjunctival, the fluid goes subconjunctival, and nothing builds up. Group 2, intermittent attacks of angle closure, iridotomy plus medical therapy. Group 3, primary open angle glaucoma with a narrow angle usually associated with one of myotics. Laser iridotomy is good enough plus medical therapy. Small constricted pupil, that's a laser iridotomy, way of the laser. If you don't have, we are in a rural area, you may have to give them a surgical iridotomy. And that's a point people should understand. Laser iridotomy, when it's available, it's nice. If it's not there, you can give them a surgical iridotomy. Small incision on the cornea, you go and cut a hole in the peripheral iris or 2 holes there. That's it. That will stop closure of the angle, because the production of aqueous is in the posterior chamber. Some of the fluid is supposed to come through the pupil, some will come through the holes you have made in the periphery of the iris, then it is filtered away. The story of saying, I couldn't do a laser, we have no laser at our place, should not be there. Is this the last one? Absolute primary open angle glaucoma, angle closure glaucoma. This is the end stage of acute congestive primary angle closure glaucoma. The eye is completely blind. These are cases, normally you see them in rural areas, being managed by non-ophthalmic personnel. Although they were common those good old days, these days they are few. Because most of the centers, major centers in the provinces, they've got nice eye centers now. The government has put in eye centers. So this used to happen before that. Even my general hospitals, they've got a small eye clinic where there's an optometrist, there's an ophthalmic clinic officer. You should be able to advise. Ladies and gentlemen, any questions? I think this is Kwamana. Let's first hear questions about this same one before we go to congenital. You say, obvious. Huh? You don't want it, don't say. You have.
I have a question, sir.
Yes, please.
Are we going to have a practical of how to do the iridotomy, or maybe we have to refer?
Say,
Are we going to have a practical of how we are supposed to do the iridotomy, or we have to refer?
How to do the what? Iridotomy. Or iridotomy. Or we refer. There will be practicals. You will be obviously there will be practicals you'll be exposed to.
Okay, sir. Thank you very much.
Thank you.
If you do iridotomy, say you create
A hole.
some holes. Yes. Now, like those holes, can it be like causing the patient to have double vision?
No.
No.
No. The reason is the holes are done in the periphery of the iris. Your vision comes through the center of the pupil. The light that goes through the center of the pupil and back onto the retina is what constitutes vision to you. So when a peripheral iridotomy is done, it's a small hole in the periphery of the iris. This cannot cause double vision. And we're not cutting a big chunk, just a small hole. And the small hole is to allow flow of fluid from the posterior chamber to the anterior chamber. The anterior chamber, the angle, that's where the aqueous goes to be filtered away from the eye. While in the posterior chamber, behind the posterior to the iris, that's where the production occurs. So you are trying to avoid the buildup of the aqueous in the posterior chamber. You learn about this because one of the things we want to include in this course is surgery, including cataract surgery. At some stage, it must be included to our clinical officers. And it's not a big deal. There are clinical officers right now who are lucky enough and were trained, and they're doing very well. So you don't have to be consultant. You can learn and you'll be doing this. Any other question, Mami? Right. 10 minutes, yeah?
For the 40 minutes to finish.
I think
For the 40 minutes to finish. So it is better.
we've got still time.
We're just remaining 6 more minutes.
Upgrade now to remove the 40 minutes time limit. Who pays for this? Levy Mwanawasa.
Via internet.
Oh, mashilingi yanga yanga ili yanga hapo nishi hapo imepita. Okay. No. Any other question, ladies and gentlemen? Hakuna. Hmm? 5 minutes. And then 5 to 13.
We start another one.
It will be nothing to do with this timing. No.